Assalamu alaikum and welcome back to Pete's Mentor. In the last video, I discussed about neonatal jaundice, especially in preterms less than 35 weeks. But I have already told you that that lecture is not complete. Various points will be discussed in the next class, so today is that class. In this lecture, I will discuss neonatal jaundice in neonates greater than 35 weeks. But why this topic is important? Why neonatal jaundice must be taught with respect? Because neonatal jaundice is not just a bilirubin topic, it is a brain protection topic. Because the real danger is not that the baby looks yellow, the real danger is that unconjugated bilirubin may rise beyond the infant's safe handling capacity. The unbound fraction may increase and the brain may become vulnerable. And that is exactly why this topic becomes dangerous when it is treated too casually. This is one of the commonest errors in newborn medicine is calling things physiologic too early. Yes, physiologic jaundice is common, but not everything common is physiologic. A baby who is jaundiced in the first 24 hours is not routine. A baby who is feeding poorly, losing too much weight, and stooling late is not just a color problem. A baby whose bilirubin is rising rapidly is not a baby you watch casually. And a baby with an elevated direct bilirubin is not physiologic at all. So, why this topic is important? Because if you find a baby which is less than 24 hours of age and is jaundiced, this is not physiologic. A baby who is jaundiced but feeding poorly should not be deal with a casual behavior. Along with this, a baby which is losing too much weight should also not to be treated as casual, whose bilirubin is rising rapidly, and a neonate which has elevated direct bilirubin. Remember, direct bilirubin in neonate is always pathological. All of this can occur along with jaundice. So you have to approach this neonates with different approach. The problem begins when all of these babies are mentally grouped together under one comfortable label, neonatal jaundice. Because once that happens, the whole topic becomes unsafe. Why it is so? Because you stop asking the right questions. You stop respecting the hours of life. You stop separating normal transition from pathology. And instead of managing the real clinical problem, you start reacting to the yellow color alone. So today, I want to draw that line properly. Where normal transition ends, where pathology begins. How to recognize the difference early, and how to think in a way that keeps you calm with the well baby, but immediately alert to the vulnerable ones. That is the real art of neonatal jaundice. So, here you will have get the answer where normal transition ends, where pathology begins. How to think in a way that keeps you calm with the well baby. It means how to approach. And these all are required whether you are an FCPS trainee, an MRCPCH candidate, a pediatric resident, a neonatal fellow, or a serious ward based learner, this is exactly the level you need. So, not just knowing that bilirubin is high, but knowing what that bilirubin means in this baby at this hour on this pathway. That is the difference between textbook familiarity and real neonatal judgment. So, in this masterclass, we are not going to approach jaundice as a flat list of causes or a few memorized bilirubin cutoffs. Here, we are going to build it the way a good neonatal clinician actually uses it. So, starting with the first part or first question, why newborn gets jaundiced easily? Why they are more prone to become jaundiced as compared to adult? Then we will discuss how to separate normal transition from pathology. Then how to approach jaundice at the bedside using age in hours. Number 4. At the last, we will move into transcutaneous bilirubin, transserum bilirubin, and American Academy of Pediatrics latest guideline for infants 35 weeks and above. That is when to use phototherapy, escalation of care, IVIG, exchange transfusion, prolonged jaundice, rebound discharge, and follow up. So, in this lecture, I want one line fixed in your mind from the very beginning. You do not treat yellow color, you treat a bilirubin value interpreted in the correct baby at the correct hour of life on the correct pathway. So, starting with this master class with the physiology, that is the bilirubin physiology. So, discussing the bilirubin physiology, but not discussing that why newborn produces bilirubin faster than an older child or adult. So, first I am discussing why neonate produces more bilirubin as compared to adult. This is because of two reasons. First one, neonatal cells have short lifespan, and second, the newborn starts life with a relatively high cellular mass. That is, they have high red cell mass. So, when red blood cells are broken down, RBCs broken down into hemoglobin, and hemoglobin is split into two, that is globin and heme part. This globin is recycled, but this heme is converted by heme oxygenase into biliverdin and bilirubin. So heme is first converted into biliverdin, and then this biliverdin is converted into unconjugated bilirubin. So here RBCs are broken down into hemoglobin. Hemoglobin is broken down into heme and globin. Globin is recycled. Heme is broken down by heme oxygenase into biliverdin, and biliverdin is converted into unconjugated bilirubin. This unconjugated bilirubin is lipid soluble, and this lipid solubility explains much of neonatal jaundice. So, this unconjugated bilirubin is lipid soluble, not water soluble, so it cannot be excreted efficiently in urine, and it cannot just circulate safely by itself. It's, it travels bound to albumin. So, this unconjugated bilirubin travel bound to albumin. So, remember, albumin is not a side note in this topic. Albumin is part of the baby's protection against the toxic unbound fraction. So, here, level of albumin is as essential, as important as other part of this topic. This albumin bilirubin complex reaches to the liver, so it arrives at liver, and then it is taken up by the hepatocytes, enter into liver cells, that is hepatocytes, where it is conjugated by an enzyme. So here it forms a conjugated bilirubin by enzyme which is UGT1A1, and this conjugated bilirubin is water soluble and can be excreted into bile. So this is all about the physiology. Why neonates are producing more bilirubin as compared to adult? Because of two reasons. First is the short lifespan of RBCs, and second, the red cell mass are more as compared to adults. So these RBCs are broken down into hemoglobin, and this hemoglobin into heme, and heme into biliverdin, and this biliverdin is into unconjugated bilirubin. This unconjugated bilirubin is lipid soluble, so it cannot be excreted efficiently in urine, and it travels, if it travels unbound, then it can reaches to brain and cause neurotoxicity. So it bounds to albumin and then reaches to the liver, where it is conjugated by enzyme UGT, which means that this conjugated bilirubin becomes water soluble, and this can be excreted in bile. Now look at the newborn situation. The baby is producing more bilirubin, that is, they have increased bilirubin. Their liver is immature, so the conjugation is not proper. So conjugation is immature. Their enterohepatic circulation is more active, more enterohepatic circulation. And when feeds are poor and stooling is delayed, more bilirubin stays in the gut, gets deconjugated, and gets reabsorbed. So, if along this feeding is poor, and stooling is delayed. This also led to increased deconjugation and increased reabsorption of bilirubin. So, physiologic jaundice is not one isolated defect. It is the combined effect of increased production, immature conjugation, increase in enterohepatic circulation. That explain why jaundice is common. But common doesn't mean harmless. Here we have two types of bilirubin, unconjugated bilirubin and conjugated bilirubin. But the main fear is the unconjugated bilirubin. If it exceeds to the neonate safe handling capacity, once that rises enough, bilirubin can cross into the brain and produces bilirubin induced neurological dysfunction. In severe cases, that becomes acute bilirubin encephalopathy and later kernicterus. So, the main fear is unconjugated bilirubin. If it increases greater than the limit of safe handling of neonate, then it leads to neurologic impairment or toxicity, which can lead to kernicterus. So, I have already told you that neonatal jaundice is not a cosmetic topic, it is a brain protection topic. And that is why shortcuts in this area become dangerous. Now, after the bilirubin physiology, we come to the topic that how to separate normal transition from pathology. That is, here we are discussing normal versus pathology. This normal transition and the pathological separation is the most important in the whole lecture. A newborn can be jaundiced because the newborn is transitioning normally, or the newborn can be jaundiced because the newborn is in the trouble. So, your job is not just to list causes of jaundice. Your job is to decide which side of that line this baby is on. Normal transition usually means a baby who is otherwise well, who is clinically stable, feeding properly, stooling properly, and becoming jaundiced in an expected time window with a bilirubin pattern that makes sense for age in hours and gestational age. Means their bilirubin is not rising rapidly. While the pathology becomes more likely when one or more of the following are present. The jaundice is early, that is less than 24 hours of life. A baby is less than 24 hours of life and is jaundiced, means this is not normal transition, this is pathology. The bilirubin is rising too rapidly. Rise of bilirubin is too rapid. The baby has hyperbilirubinemia and have neurotoxicity risk factor. They are feeding poorly, having delayed stooling. Baby is clinically unwell. They have risk factor of hemolysis. Or one more important point, that direct bilirubin is raised. Increase conjugated. That means the same bilirubin number can be reassuring in one baby and dangerous in another. Let's take a look. A day 4 thriving infant feeding vigorously with yellow stools is not interpreted the same way as a day 1 infant who is already visible jaundiced. So, from this point onwards, never think of bilirubin as an isolated lab number. Think of bilirubin as a number that one becomes meaningful after you answer 5 questions. So, remember you have to answer these 4 questions and then label is it either the normal physiology or the pathological. The first one, what are these 5 questions? Number 1, how many hours old is the baby? Number 2, what is the gestational age? Is the baby well or unwell? Clinical status. Is feeding effective or not? And the last one, is this unconjugated jaundice or is there a direct bilirubin problem? So, what fraction is increased? If you answer these 5 questions properly, your management become much safer. Now, we will try to answer these all these questions. When you approach neonatal jaundice, the first question is not how yellow is the baby. The first question should be how old is this baby in exact hours. So, your first question should be how old the baby, and this should be in exact hours. So, if you know the age of the baby, you can interpret jaundice easily. Remember, if jaundice is visible within the 24 hours of life, and second second day onwards, if a neonate is jaundiced in less than 24 hours of life, remember it is pathologic until proven otherwise. So, if it is less than 24 hours, you have to measure bilirubin immediately. Do not reassure yourself with the visual impression. Do not say the baby looks okay otherwise, and do not leave the decision for the next shift. In practical situation, early jaundice means hemolysis until proven otherwise. So, one of the commonest reason of jaundice in 24 hours of life is due to hemolysis. Although sepsis, significant bruising or hemorrhage and rare conditions can also present early. But hemolysis is one of the common cause of neonatal jaundice if it appears in less than 24 hours of neonate. So, if a baby is 14 hours old and visibly jaundiced, that baby does not belong in the mental box called routine nursery jaundice. That baby belongs in the mental box called urgent explanation needed. So, this is not a physiological jaundice, this is pathological. Secondly, in the first 24 to 72 hours, means second day to third day, this is the zone where physiological process and pathological processes overlap. And this is where trainees often become too comfortable. Yes, physiological jaundice often becomes visible here. But this is also the classic period for jaundice related to poor intake. And remember, the language also matters here. A day 2 or day 3 baby with poor milk transfer should not be lazily labeled as breast milk jaundice. The more useful concept early on is suboptimal intake jaundice. So, here we should use suboptimal intake jaundice instead of breast milk jaundice. Because the problem here is not that breast milk is bad, the problem is that milk transfer is inadequate. That is, the baby is feeding improperly or too infrequent. Volume is insufficient, weight loss becomes significant, meconium passage is delayed, enterohepatic circulation rises, and bilirubin climbs. So, why we are using suboptimal jaundice here? Suboptimal intake jaundice, because we know here the problem is not that breast milk is bad, but the main problem is that milk transfer is inadequate. Baby is taking feed ineffectively, means feeding less, having volume inefficient, weight loss due to this increases, and due to all these, enterohepatic circulation also rises because of delayed stooling, and all these factors led to increase bilirubin. So, if you see a baby who is on his third day of life, sleeping at the breast, still passing black stools, losing weight, and becoming more yellow, that is not the moment for casual reassurance. That is the moment for feeding assessment, weight interpretation, lactation support, and bilirubin measurement in the context. So, here, if you see a baby who is day third of his life, but they are too sleepy, passing black stools, losing weight, and becoming more yellow, in this moment, you have to assess all these. That is, you have to see for feeding. So, you have to assess feeding. You have to interpret weight. Either neonate is losing weight aggressively or not. You have to support lactation. And the most important, you have to measure bilirubin as per the graph. Now, in the second week or later in the first week, here the thinking change a little. If the infant is feeding well, clinically stable, passing urine and stooling properly, and starting to gain weight, but the jaundice is still present or seems to peak a little later, the breast milk jaundice becomes a more reasonable possibility. So, At the end of the first week or later in the second week, breast milk jaundice is a possibility. In a well fed baby, passing urine and stooling properly, and gaining weight. Remember all these points before labeling any unit as breast milk jaundice. That is very different from the baby whose jaundice is being driven by poor milk transfer. Here, the jaundice is due to poor milk transfer, less feeding, decreased feed volume, increased weight loss, increased enterohepatic circulation due to late stooling or delayed stooling. So here bilirubin is increasing due to all these factors. But if a neonate is feeding properly, having normal intake and thriving normally, so these babies are different from here. This is due to a factor which is present inside the milk, and due to this, jaundice appears at this age. But even here, do not become lazy. Before you settle on breast milk jaundice, the story still has to fit. The baby should be clinically well. The bilirubin should be unconjugated, and red flags such as pale stool, dark urine, illness, poor growth, or an abnormal direct fraction should not be present. So, before labeling that this unit is having breast milk jaundice, you have to rule out all these. That is, baby is clinically well, baby is feeding properly, the fraction is unconjugated, not the direct one, and red flags such as pale stools, dark urine, any type of sepsis, poor growth, or an abnormal direct fraction should not be present. Now, the next section of this topic is why the rapid rising bilirubin matters. A rapidly rising bilirubin is a red flag even before the absolute number becomes dramatic. So you have to remember few numbers over here. A rise of zero point 0.3 milligram per deciliter per hour or more in a neonate in the first 24 hours, or zero point 0.2 milligram per deciliter per hour or more after 24 hours. These rate of rising of bilirubin strongly suggest hemolysis, and you have to sharpen your thinking immediately for this. So, the clock matters, but the clock is never interpreted alone. The safe approach is always the clock plus feeding plus weight loss plus stooling plus clinical condition. So, remember, you have to combine all these. First one is age in hours, along with feeding, along with weight of the neonate, along with stooling and clinical condition. So, all these points can only be dig out by history. So, let's move to the bedside, the way a real neonatal clinician does, not the way a handout does. So, starting with the high yield identity questions. First one, how many hours old is the baby right now? So, hours of the baby means exact age of the neonate you should know. Second, what is the gestational age? Was the baby term, late preterm, or early term, early preterm? And remember, the American Academy of Pediatrics 2022 management thresholds we are discussing today apply to infants 35 weeks and above. If the infant is below 35 weeks, then you should watch the video I have uploaded earlier to this. You can find it in the playlist as well. After you know all these, you have to ask few questions to rule out the causes of jaundice. So, you have to dig out birth and perinatal details. Starting with the delivery, is the delivery normal or traumatic? Was any instrument used, that is vacuum or forceps used? Is there any bruising or cephalohematoma? This is important. Did the baby have delayed cord clamping, polycythemia, or significant birth trauma? Delayed cord clamping, polycythemia, or major birth trauma. Cephalohematoma is not a cosmetic finding here. It is a blood collection that becomes a bilirubin load over the following days. Now, after this, you have to dig out about maternal blood group and hemolysis history. You have to ask mother's ABO group and RH type. So, you ABO type along with RH type of mother. Ask about whether the maternal antibody screen was positive. Positive or not. Ask whether there is known incompatibility. Known. Ask about previous siblings who needs phototherapy, exchange transfusion, or had severe jaundice. So you have to ask about previous siblings as well for phototherapy, exchange transfusion, or had any severe jaundice. After this, you have to dig out in detail about the feeding history. So, feeding history should not be, is the baby feeding okay? This question is too vague to be useful. So, you have to ask efficiently. So, First one should be, how often does the baby feed? Number of feed. How long do feeds last? Duration of feed. Does the baby actively sucks and swallow? Does the baby wake for feeds or remain too sleepy? How many wet diapers are there? How many stools? Have stools changed from black meconium to green, transitional to yellow? Stool color. So, in feeding history, you have to dig out the number of feeds baby having in a day. Duration of feeding. Is baby is actively swallowing or feeding or not? Is baby wake for feed or remains too sleepy? Number of wet diapers and how many stools and stool color. These all are important. If a day 4 baby is still passing black stools and losing too much weight, it means the baby is not active in feeding, and this can lead to pathological jaundice. Now, after feeding history, you have to ask about family history. And in family history, the one most important is G6PD deficiency. You have to rule out RBC's defect as well. So you have to ask about a specific condition like hereditary spherocytosis, any anemia in family, splenectomy, gallstones, or recurrent neonatal jaundice in the family. After this, you have to examine the baby. So, now comes towards the examination. Remember, do not use your eyes as bilirubin meter. Remember, visual assessment is unreliable, especially after the first day, and it cannot tell you whether jaundice is unconjugated or conjugated. So, do not use your eyes as a bilirubin meter. Use the examination for different questions. Is the baby well or unwell? Is there bruising or cephalohematoma? Is there dehydration? So look for bruising, cephalohematoma, clinical condition, dehydrated or not, any dysmorphic features, any signs of congenital infection, stool is pale or normal in color, is the urine dark urine color, what is the neurological state? This is more important in examination because once neurological signs appear, this stops being routine jaundice management and becomes potential acute bilirubin encephalopathy. So, neurological examination is important, and early concerning signs include poor feeding, lethargy, hypotonia, and weak sucking. These are the early signs. More advanced signs are irritability, hypertonia, retrocolis, opisthotonous posture, high pitched cry, and recurrent apnea. So, if you see any of these signs, you have to escalate management urgently. Now, after this, you should have a clear in your mind that if this bilirubin is unconjugated or conjugated. Remember, most neonatal jaundice are unconjugated, but once the direct or conjugated fraction is elevated, you have crossed into a different clinical problem. Conjugated hyperbilirubinemia is never physiologic, it is always pathologic. So, if the direct fraction is elevated, you have to start thinking on the pathological condition it may cause, that is cholestasis, biliary disease, that is biliary atresia, hepatic injury, any congenital infection, endocrine problems, or metabolic problems. But remember, a mild direct bilirubin value is not interpreted in exactly the same way at all ages. In the 2 to 4 weeks window, a direct or conjugated bilirubin of 1 milligram per deciliter or more deserves urgent pediatric gastroenterology discussion because bilirubin atresia is time sensitive. So here you have to send this child if he or she have conjugated bilirubin value 1 milligram per deciliter or more. Now the question arises, when to fractionate in a baby if you are suspecting prolonged jaundice. If a formula fed infant is still jaundiced at 2 weeks and the infant is formula fed, you have to fractionate it. So you have to measure total and direct bilirubin over here. And if a breastfed infant is still jaundiced at 3 weeks, you have to fractionate it to measure total and direct bilirubin. Unless there is already an earlier reason to fractionate because the stools are pale, urine is dark, the infant is not thriving, or the examination is abnormal. So, If you have a 3-week old breastfed infant who is thriving, is still a little yellow, passing pigmented stool, and has no hepatomegaly, you should not panic. But you also do not wave it away without checking what fraction of bilirubin you are dealing with. So, if the direct fraction is elevated, means if a 2-week infant with formula fed or a breastfed infant at 3 weeks of age have direct bilirubin raised, this is not breast milk jaundice until proven otherwise. This is cholestatic jaundice. So it should be treated as cholestatic jaundice. Now you have to ask about pale or acholic stools. Ask about dark urine. Look for hepatomegaly. Review the newborn screen. Think about hypothyroidism, infection, metabolic disease, or biliary atresia. So here you have to think about hypothyroidism. You have to think about biliary atresia. You have to think about infection or any metabolic disorder. And if the prolonged jaundice is unconjugated and the baby is thriving, then breast milk jaundice becomes much more plausible. But even then, that diagnosis should fit the whole story. So, if an indirect fraction is raised in a baby who is thriving well, this can be due to breast milk jaundice. But even then, you have to dig out or rule out other causes as well. So, I have discussed in detail how to approach a neonate which is greater than or equal to 35 weeks. This is the second video lecture related to neonatal jaundice. Inshallah, in the next lecture, I will discuss about the management plan related to this. So, if you have any query related to this topic, you can ask me in the comment box. But remember one point, these lectures are purely for educational purposes. These videos are not intended for any clinical decisions. So if you have any query, you can ask me. Till then, Allah Hafiz.